Very good morning to all of you, and good afternoon and good evening to all others who are joining from rest part of the world. Today, our guest speaker for the day is Dr. Chetan Damne from Mumbai, and he's going to lecture us on ALL maintenance in pediatrics. This webinar, as usual, is brought to you by Mumbai Hematology Group, supported by Adley Oncology, and very well managed by Perfect Square. I thank Mr. Ashutosh Shukla and team from Adley, Mr. Yash, Mr. Kalpesh, and the team from Perfect Square, Executive Committee of Mumbai Hematology Group. Our chief guest for the day, Professor Dr. Surgeon Commander Gaurav Narula from Mumbai. Our guest speaker for the day, Dr. Chetan Damne from Mumbai. All our discussions were themselves very eminent pediatric hematologists and oncologists, and you participants for sparing a Sunday morning, afternoon, or evening from whichever part of the world you logged in. Let me give flavor for next weekend activities. Next Saturday, that is 4th of April 2026, we have got two lectures. The lecture 1 is at 6:15 p.m. Indian Standard Time on Teclistamab, the new kid on the block with updated indications by Dr. M.B. Agarwal sir from Mumbai. And the lecture 2, this is at 7 p.m. Indian Standard Time and 9:30 a.m. Eastern Time on AL amyloidosis by Dr. Rajshekhar Chakraborty from Colombia. And the following day, that is Sunday, 5th of April 2026, from 11:30 a.m. Indian Standard Time, we have again Dr. Ankur Ahuja from FMC Pune speaking to us on morphology is not extinct, reclaiming its power in the era of molecular hematology. Let me introduce our discussions for the day, and we have a galaxy of them here displayed in alphabetical order. I will pause for a while for you to look at all our discussions for very eminent hematologists, hemato-oncologists, medical oncologists, pediatric hematologists, as well as hematopathologists all across the country. Some more over here. So these are our discussions for the day. And now it's time to introduce our guest speaker for the day. We have with us Dr. Chetan Damne from Mumbai. Let me introduce Dr. Chetan Damne to all of you. Dr. Chetan Damne is professor at Pediatric Oncology, Tata Memorial Hospital, Mumbai. He completed his MBBS from Mahatma Gandhi Institute of Medical Sciences, Sevagram, Wardha. This was followed by pediatric training from Cook County Hospital, Chicago. Because of his interest in research, he went to Penn State, Hershey, and completed a master's in integrative biosciences. Subsequently, he joined MD Anderson Cancer Center in Houston for his fellowship in pediatric hematology oncology. During his training, he was inspired by his mentor, Dr. Lawrence Cooper, and got interested in cellular therapy. He moved to National University Hospital, Singapore, where he worked as a consultant and was involved in NK cell trials for AML and neuroblastoma with Dr. Dario Campana. After his return to India, he joined Tata Memorial Hospital and he continues to work on cell-based therapies till date. In collaboration with Dr. Hassan at ACTRAC, the team has developed cytokine-induced memory-like NK cells for acute myeloid leukemia. He is also working on other cell-based therapies that are in early preclinical development. He is also interested in applying technologies to solve challenges in pediatric leukemias. With the data manager team at TMH, he has developed an app to track maintenance therapy for outstation children with ALL. He is also interested in neotherapies for AML and is working on the AML registry for pediatric AML. And today is with us and is going to lecture us on ALL maintenance in pediatrics. But before he does that, let me introduce our special guest and chief guest for the day. We have with us no other than Professor Dr. Gaurav Narula from Mumbai. Let me introduce Dr. Gaurav Narula to all of you. He is a professor at Pediatric Oncology and Health Sciences at Tata Memorial Hospital, Homi Bhabha National Institute, Mumbai. He has previously served in the Indian Navy for almost 25 years till 2012. He was professor and classified specialist pediatrics and hematology at INHS Aswini, Mumbai. He is past convener for the Pediatric Hematology Oncology Lymphoid Group, that is PHLG. The PHLG manages more than 1,000 newly diagnosed children with leukemia, lymphoma, and LCH a year. His research is focused on improving their outcomes with innovative approaches, including low-cost alternatives, improving supportive care using innovative technologies like CAR T cells developed indigenously at IITB and developing a cellular therapy center at TMC. He is also the editor-in-chief Pediatric Hematology Oncology Journal. is also a founder, president of Immuno-Oncology Society of India. It's my privilege to welcome Professor Dr. Gaurav Narula to inaugurate our webinar and give some words of wisdom. Well, thank you so much. I stop over here. Over to you, sir.
Thank you very much for that kind introduction, Dr. Pranav. This is very nice of you to do that. It's a privilege to be here today as part of this webinar, and especially because the speaker today is my dear friend and colleague, Dr. Chetan Thamne. ALL has been, the most curable malignancy in children and amongst, in fact, amongst all malignancies, probably with the exception of Hodgkin lymphoma. And we've been reaching high cure rates for several decades now. But we do continue to flounder in certain aspects of ALL. And one key component of that is maintenance therapy. Most of the initial therapy with intensive and under supervision, but during maintenance, often the intervals of follow-up are longer. And this is the time when probably the eye goes off the ball. I think maybe 5 to 10% of relapses would be attributable to probably not having a tight control during the maintenance period. It's a very crucial area, despite the developments that we have seen. And we talk about CAR T-cell therapy and chemotherapies now. But if we don't stick to the basics, we will not be able to see the incremental income that we are seeing with these newer therapies. So it is really a pleasure to hear Chetan will be speaking about this very, very important topic. So with that, I would like to hand over back to you to continue the proceedings.
Thank you, Dr. Gaurav Narula, for kind words of wisdom, and thank you for accepting us as our chief guest for the day. Thank you so much. And now, Dr. Chetan Damne, sir, screen is yours.
Thank you so much for that kind introduction. Thanks, Dr. Gaurav, for having kind words for me. And today I'm going to discuss a little bit about maintenance therapy. And as Dr. Gaurav has already mentioned, it is a very important part of treatment, and a significant proportion of relapses might be because of inadequate maintenance or inappropriate maintenance. So this is a recipe that has to be individualized for each patient. That is how I would put it. And it is like cooking. You add a little bit of methotrexate, you add a little bit of 6-MP, you titrate salt a little bit up and down. So that is how you want to titrate your maintenance. So first, let us go to some of the historical perspectives. So in the UK, what they did was they tried to see how outcomes are based on the 6-MP dosing before and after 1980s. So before 1980s, what they were doing is that they were interrupting therapy for any transaminitis when they felt like the patient has elevated liver enzymes or any neutropenia. So there are multiple reasons that they were interrupting therapy. And also it was left to individual physicians. So any physician who felt that this patient has become neutropenic with an ANC going lower would interrupt therapy. So what they did was in 1980s, they made a rule saying that your WBC count should be between 2000 and 4000. And they titrated the dose of 6-MP such that it will be slightly higher. So the dose increase in 6-MP as per the protocol was only 9% higher. But when they actually calculated the dose that was delivered, it was 22% more than what was delivered before 1980s. And that led to 18% improvement in relapse-free survival at 5 years. So almost the same dose, but the dose that was delivered was much more because there were no interruptions, and the outcomes were increased by around 20%. So it was seen that a higher dose had better EFS, right? So the first thing they identified was giving a higher dose is good. Now, when they analyzed the patients after 1980s, they found that those who received lower dose had better outcomes. Now, this is counterintuitive. Okay, but let me clarify what the lower dose meant. So those who received lower cumulative dose because of toxicities. So they had neutropenia and their dose had to be titrated slightly lower. Those did better than those who tolerated very well and their WBC count was higher. So that means they are not achieving adequate myelosuppression. That is why they are tolerating the dose very well. So in spite of getting a higher dose and not having any toxicities, they did poorer because maybe the myelosuppression was not as great. So a lower dose did better because the dose had to be titrated lower because they had toxicities. So lower dose, delivered dose does not mean that the dose was inadequate. It was adequate for that individual patient or most of the patients, but it was the ceiling dose that the patient could receive. So before 1980s, higher dose. After 1980s, they felt that the lower dose did better. But again, the message is optimal dosing was what was essential. So this was worked out by multiple people, and then they felt that if you want to give a higher dose, maybe it can be given IV. So in St. Jude, total 12 protocol, they gave oral 6-MP and IV methotrexate with pulse chemotherapy every 6 weeks. So here there is something called the dose intensity, and we'll come to different definitions. So the dose intensity is the dose delivered divided by the protocol dose. So the protocol prescribes a particular dose, and what was the dose delivered out of the prescribed protocol dose. Here they felt that they wanted to give a higher dose. So they were interruptions only if the ANC was below 300 cells per microliter, that is the ANC, or if there were complications like fever, mucositis, or hepatotoxicity. So what this figure shows is that this is the dose intensity of 6-MP delivered at particular weeks. Okay, so every 3 months they saw how much dose was delivered, and obviously where the dose delivered was higher, those patients did better. So the gray bars did better, while the incidence of relapse was higher in those who had the lower intensity of 6-MP. So higher intensity was important. In this, they had also given tinoposide and cytarabine, which was individualized based on the pharmacokinetics of the or the dose levels that they were monitoring, drug level monitoring that was done. So they felt that those who received individualized dosing did better as compared to conventional dosing. But they felt that if the delivered dose, that is the dose intensity, was more than 85% of 6-MP, those were the individuals that did best. So you have to have 85% of the protocol dose delivered to achieve good outcomes. Okay, so that is a pretty high number. I remember I hardly got 85% in my school. So this is much more to achieve for an individual to give more than 85% of the dose as per the protocol. So what was the observation? Here you see missed doses of 6-MP were 24%, and here it was 7%. So if you want to achieve that higher dose, the delivered dose, you have to miss very little of 6-MP. So the average 6-MP dose delivered was 504 milligram per meter square per week. And those were the ones that had poor outcome. And those who received more, as 561 milligram per meter square per week, were the ones that did better. So again, dose intensity is important. Okay, and what constitutes dose intensity? That is the amount of dose that is delivered as compared to the protocol dose or divided by the protocol dose. So major reason for that dose, the lower dose, that is 504 milligram per meter square as compared to 561, was because there were missed weeks of 6-MP. So whenever you miss the dose, your dose intensity is going to be lower. Now here we are not comparing the dose. So there are few things that you have to understand. You want to give the optimal dose. When you give a higher dose and you have interruptions, you want to make sure that those interruptions are not longer, because when you have an interruption for 1 week, you are directly losing an entire week or 2 weeks of therapy. So your delivered dose is going to be lower. So you want to achieve the maximum dose has to be delivered. So you want to miss minimum weeks of therapy. So you have to optimize the dose. So what their observation was, they tried to look at multiple things. They not only looked at 6-MP, they also looked at methotrexate. So what they did was they calculated the RBC 6-TGN levels, 6-thioguanine nucleotide levels in the RBCs, and they also calculated the methotrexate polyglutamate levels in the RBCs. And the product of the 6-TGN and MTX polyglutamate, they felt would be much superior in the ones who had better outcomes. But that was not the case. It did not correlate with EFS. Otherwise, that is something that we would have been following now. But nevertheless, they made a very good attempt to find out what is the optimal dose of 6-MP and MTX that can be delivered. Because again, they felt that RBC TGN levels was not an indicator of compliance. It is a cumulative accumulation in the RBCs that was calculated, but then it was not an indicator of compliance. It comes at various intervals. It has to be done at continuous intervals to really find out whether there is a consistent dosing that was delivered. Then the median and minimal levels of 6-TGN and MTX polyglutamates were higher than the threshold value for efficacy. So what they are saying is that maybe you have a particular band in which you want to achieve your 6-MP and TGN, 6-TGN and MTX polyglutamates. Okay, so if you are exceeding that threshold, then that is not going to be helpful. Okay, so the higher level does not correlate with outcomes because you are far exceeding what is optimal. So exceeding that does not help. So higher product does not mean that you are giving optimal dose. You might be giving higher dose and causing more toxicity, leading to multiple dose interruptions, and that is not going to be helpful. And in that they found was neutropenia was associated with worst EFS. So when we try to give 6-MP MTX, we want to achieve that optimal neutropenia and not cause interruption. So when you have prolonged neutropenia, it is associated with worse outcomes. So weeks where dose intensity was analyzed. They analyzed that, okay, these patients are missing the 6-MP dose. Okay, so what is going to happen is that we are trying to calculate the amount of 6-MP that was delivered. So they found out if in a week you give at least 3 days of 6-MP, then those patients did much better than those who did not receive 6-MP in that entire week. Okay, so these are cumulative calculations. We are not talking about when you actually interrupt for a fever or anything, but when you give 6-MP for at least 3 days as compared to no 6-MP during that entire week, that was much better than for interrupting the 6-MP for the entire week. Okay, so EFS is better in those who receive at least 3 days of 6-MP during the entire week. And this is again an average. Okay, so it was seen that neutropenia that comprises the ability to deliver 6-MP worsens event-free survival. The efficacy of 6-MP depends on adequate chronic exposure of the drug over a high percentage of weeks of continuation therapy. So what does this mean? That you have to give adequate exposure, not over, not lower. You have to give adequate exposure, and it is a chronic exposure. You cannot give a lot of 6-MP during the first week, no 6-MP during the second week, and third week again you give some sort of 6-MP. So that variation is not what is useful. You want to achieve an adequate myelosuppression. Lower myelosuppression is not useful. Higher myelosuppression is not useful. It should be adequate and it should be continuous. So chronic exposure is important. So these are the things that you have to remember. Now, again, the COG tried to look at this and they felt that compliance was a problem in their adolescents. From my experience in India, most of the patients are below 15 and a lot of parental guidance is given. So parents are on top of things. So up to 15 years. So the compliance is pretty good. That's what we realize. Very few non-compliant children in our cohort. But again, here in the US, you become independent quite early and the parents can no longer dictate how you take the medicine. So what they did was they put on the cap of the bottle of 6-MP, they put a sensor. So every time the bottle was opened, they knew that they assumed that the medicine was taken. So this is adherence. So what does adherence mean? So it is number of 6 MP doses actually prescribed upon the number of planned protocol doses. So it is very similar to intensity, okay, but here it is the number of doses that are prescribed and the number of doses that are taken. So slight difference, but eventually it boils down to the same. So they looked at adherence or compliance, okay, and adherence was defined as the ratio of days that a 6 MP bottle was opened to the days of 6 MP bottle that was prescribed. Again, if you have an interruption, your adherence is going to go down. But here it is, adherence means how sincere the patient is. It depends on the patient. While intensity is the intensity will go down if you have fever, if you have neutropenia. So those are not patient-related factors. Here it is patient-related factors where the compliance of the patient depends entirely on the patient. So if the patient is very religious in taking his doses, then his outcome is going to be better. Okay, and they calculated everything, the intra-individual coefficient of variation, stable versus varying. So what they found out is that those who are non-adherent obviously had higher incidence of relapse, while those who are adherent, they had lower incidence of relapse. So non-adherence had increased incidence of relapse. And non-adherence here was defined as less than 95%. So that is a very tall order. You have to take the medicine by yourself at least 95% of the time. So if you miss even 5% of your doses, okay, you're not taking the doses willingly, then your outcomes are going to be inferior. So 95% is a very tall order. So you have to take 95% of the days of the 105 weeks that you're taking. Okay, you have to make sure that you're taking those doses. Okay, so there was a 2.7-fold increase in risk of relapse if you are non-adherent. Okay, so I just want to again bring the concept. Intensity is the maximum dose delivered. Okay, it's not the number of days that you give it, it's the maximum dose delivered. Of course, multiple things are calculated. So intensity is maximum dose delivered, and that has to be more than 85% of the protocol dose, while adherence is the number of days you take the 6 MP, and that has to be more than 95%. So that is a pretty tall order. Now, the next thing that you have to see is that there is intra-individual variability. Within the same individual, your dose can go up, down, up, down, up, down. So if your variation within the same individual is very high, then again you have an increased risk of relapse. So again, that optimal dosing is important and you have to give it continuously. So boils down to the same message, but various ways of looking at it. And these are the statistics that have come out. So what matters? You have to achieve a higher dose intensity. So obviously, if your dose intensity was higher, okay, here your in cumulative incidence of relapse was lower, and if you had a lower intensity that was delivered, your cumulative incidence of relapse was higher. Varying doses. So if you have a varying intensity of dosing, then your cumulative incidence of relapse is going to be higher. If you have a stable dosing, you are going to achieve a good outcome. They calculated the TGN levels because you want a biomarker, right? Everybody says this is all subjective. You want something that is objective, and they did the TGN levels, and that was not really statistically significant. Okay, so of course, higher TGN level is going to be better, but not so much of a difference. That was not statistically significant. P-value of 0.3. Then again, same things, probably the same slide. Okay, so taken together, these findings from the studies emphasize the need to maximize adherence to 6-MP maintenance therapy regimens and to maintain steady thiopurine exposure to minimize relapses in children with ALL. So one of the things that practically is important for us is to remember that you cannot give 5 days of 6-MP and 2 days off. Okay, so if you can give 3 days of one tablet and 4 days of half tablet, that is much better than giving 5 days on and 2 days off, because you want to maintain that continuous exposure to 6-thioguanine. Got the point? Okay. So now this looks exceedingly complex, but I'm going to simplify it for you. And these are some of the basics of maintenance. So in maintenance, you use two drugs. One is MTX, and can you see my cursor? I just want somebody to tell me if you can see.
Yes, we can see your cursor.
Great, thanks. So this is the methotrexate. This is 6-MP, and this is 6-thioguanine. Okay, all three drugs have been used in maintenance in various time frames, and we will see how that works. So the methotrexate is polygglutamated to form methotrexate polyglutamates, and you have 6 to 7 glutamine residues attached to the methotrexate that prolongs the exposure of methotrexate into the cell. So how does methotrexate act? It prevents de novo purine synthesis. So what are the purines? Adenine and guanine. So just remember, adenine and guanine are the purines that are synthesized, and through inhibition of dihydrofolate reductase, your especially guanine synthesis is affected. So you no longer have guanine or lower rate. There is no absolute in medicine, you have to remember. It is not 100%, but you try to bring down the glutamine residues in the cell. What does 6-MP do? 6-MP is converted to 6-thioguanine triphosphate, and that is incorporated into the DNA. So thioguanine triphosphate, it is a guanine triphosphate. It gets incorporated into the DNA. What does it replace? It replaces your guanine. So if you have increased thioguanine triphosphate, it is going to replace your guanine. Now, if methotrexate was not used, your thioguanine triphosphate will be easily kicked out, and the regular wild type guanine will be incorporated into DNA. So inhibition of this de novo purine synthesis is equally important, so that more 6-TGN is incorporated into the DNA. Correct? So methotrexate prevents guanine formation, and you are giving a decoy 6-TGN that goes incorporates into DNA. It is said that around 1 in 6,000 base pairs will have 6-TGN incorporated into DNA, and that is something that they feel might be optimal. Now, 6-MP has to undergo multiple phosphorylations and modifications to form 6-TGN. What does 6-TG do? 6-TG directly goes to thioguanine monophosphate, diphosphate, triphosphate, and TGN, right? So why not use 6-TG? So again, people are not they will work out all these things. All these questions have been answered in previous trials, and they felt that 6-TG and 6-MP, whenever they did a comparison from retrospective studies, they felt that EFS was definitely better, okay, but it did not matter in the overall survival. So it did not affect the overall survival. The event-free survival was slightly better by using 6-TG. Again, 6-TG had increased risk of developing VOD or sinusoidal obstructive syndrome. So hepatotoxicity was much higher with 6-TG. So they felt that 6-TG is not going to be very superior. But now the altogether team is trying to look at incorporating lower doses of 6-TG, which will not cause hepatotoxicity, along with 6-MP, so that you can get increased levels of 6-TGN incorporated into the DNA. So that is the strategy that is being used. So you looked at methotrexate, you looked at 6-MP. Now we look at some of the problems that can occur. Okay, so 6-MP is metabolized to thioinositol monophosphate. It is converted to thioguanine monophosphate, thioguanine diphosphate, triphosphate, 6-TGN. Okay. Now you see here 6-MP is also metabolized by xanthine oxidase to thiourea acid and TPMT2 methylated 6-MP metabolites. So you see the methyl group is attached here. It's methylated 6-MP metabolites. Now is this necessary? Yes. 6-MP, methylated 6-MP metabolites are the ones that cause your toxicity. The hepatotoxicity is caused by them. It is said that your low appetite is also attributed to 6-MP methylated 6-MP metabolites. So you want to reduce them, but is it advisable to reduce them? Then you use 6-TG. But 6-MP methylated 6-MP metabolites also in turn inhibit de novo purine synthesis. So a little bit of that is also important. Okay. And the further metabolites of 6-MP, like thioinositol monophosphate, when it is methylated, it also prevents de novo purine synthesis. So you're not entirely dependent on methotrexate, though it is very important component. But 6-MP also adds to the prevention of de novo synthesis of guanine, and that is also an important aspect. So 6-MP is still the most important drug in addition to methotrexate. And you cannot replace it entirely with 6-TG. Now, one of the things that obviously many of us face is that if you have a lot of 6-MP, methylated 6-MP metabolites, can you use allopurinol to prevent that? So yes, so allopurinol is a xanthine oxidase inhibitor. It also inhibits TPMT. So by giving allopurinol, you are forming less of methylated 6-MP metabolites, okay, and more of 6-TGN is formed. So in a case where you have a lot of hepatotoxicity, you can replace or you can add allopurinol and reduce the dose of 6-MP and achieve a similar effect. Of course, you're using methotrexate to inhibit the de novo synthesis. And as I said earlier, it is not 100% inhibition. So there will be some methylated 6-MP metabolites that will be there to prevent the de novo purine synthesis. So that was about allopurinol inhibiting TPMT and xanthine oxidase. So more of 6-MP is available to convert to 6-TGN. This is fine. Okay. Now, as you see here, we have some patients who are very sensitive to 6-MP, and you have to give them a lower dose. So there are two such mutations that are very important. One is the TPMT mutation, and now it is very obvious, right? If you are a TPMP mutant and you are not forming a lot of 6-MP methylated 6-MP metabolites, you have more 6-MP that is available to be converted to 6-TGN. So you are cutting off this pathway and more 6-MP is being converted to 6-TGN and it is being incorporated into the DNA. So obviously, if you are TPMT deficient, you have more 6-TGN levels. So a lower dose of 6-MP is sufficient to achieve your neutropenia that would otherwise be required because of the TPMP mutation. What NUDT 15 does, it dephosphorylates triphosphate, thioguanine triphosphate, diphosphate, and converts it to 6 monophosphate, TGN6 thioguanine monophosphate. So it dephosphorylates your end product. Because it is dephosphorylating, you are trying to achieve a balance, and in the absence of NUDT 15, your dephosphorylation is not occurring. So you have this pathway that is committed, and obviously you will have higher 6-TGN levels that get incorporated into the DNA. So NUDT 15, which we see more commonly in the Asian population, and TPMT, which is seen more commonly in the Western population, are the two mutations that are important. And having those mutations will lead to higher sensitivity to 6-MP, and you have to give a lower dose of 6-MP when you are having these mutations. This is being done by pharmacogenomics, pharmacokinetics, and pharmacogenetics in many centers in the West. But you are using 6-MP earlier in the protocol, and if you find that that causes a lot of neutropenia, then selectively you can send those patients to identify these mutations. Not all patients need this, okay, because our is a resource limited country. So you can do these mutations if you find that during your earlier protocols, during the intensive therapy, if you find that there is a lot of myelosuppression, you can send these mutations, or you can titrate the dose without looking at these mutations, considering that you know the science of it and you feel that these patients will be exclusively sensitive to 6-MP because of these mutations. And again, it is not, there are certain mutations that are novel, which are not being done by a routine studies. So you might still miss out on them. So it is not very essential to know these mutations, but it is good to know. And if it is possible, you can do it for your patients. Okay. Now you can see here, this is PRPS1, this is NT5C2. Okay. So, and this is MSH6. Okay. So these are the pathways for resistance to 6-MP. Okay. And we'll not go into the details, but there is gain of function mutation of PRPS1, NTC25, again, a gain of function mutation, because it will convert your monophosphates to thioinosine. So it will take away the thioguanine from the pathway that is leading to the 6-TGN. So it robs your 6-TG's metabolites. Okay. Again, here, how this cell goes into apoptosis. So what happens is you have a mismatch repair. So you are giving, instead of guanine, now you are giving 6-TGN. The 6-TGN is methylated and instead of pairing with cytosine, it will pair with thymine. Okay, so because of this mismatch, okay, if you have a robust mechanism to identify a mismatch in the DNA sequence, what is going to happen is your mismatch repair system is going to be triggered. And if there are a lot of mismatches, it is going to lead to DNA strand breaks and the cell is going to undergo apoptosis because your mismatch repair system is robust. If your mismatch repair system is not present, like your MSH6 mutation, okay, this is your CMMRD. So if your MSH6 is not functional, these mutations will not be detected and a repair is not going to happen. So the cell is not going to say that there is something wrong and keep on proliferating. Of course, it will lead to more mutations and higher genomic instability, but the cell is not going to undergo apoptosis. So your leukemia will continue to progress. So these are some of the things. It will cause neutropenia, okay, but it will not lead to the desired effect where we want to get rid of the residual leukemic cells that are present at the end of intensive chemotherapy. Those are coming into circulation or going into the synthesis phase. Okay, so again, you have this diagram available. You can go through it, and once you go through it once or twice, you will remember all these things very easily. Okay, now coming to the practical aspect. So all theory is fine, but how do you manage the patient? So I have taken some rules from the icicle study. These are all the rules that are mentioned in the icicle study, and then we will discuss how uh, there is no ideal way how I feel we should manage the maintenance in patients for ALL therapy. Okay, so this is for most of the patients. Now we consider that don't consider NUTT15 and TPMT for this discussion. Okay. So you start the antimetabolites at 100% of the prescribed dose when you start your maintenance one. And the dose for icicle is 60 milligram per meter square and methotrexate is 20 milligram per meter square, okay, per week. This is lower than what is prescribed in the West. There's a theory that there is a lot of supplementation of folic acid in the foods that are available in the West. So for our population, 60 milligram per meter square is good enough. Some Asian countries also use 50 milligram per meter square in their protocols. Okay. So 6MP at 60 milligram per meter square per day and MTX at 20 milligram per meter square per week. So you round off the doses to the nearest tablet strength. So you give 6MP at 12.5 milligrams. So a quarter is what you can break the tablet into, and oral methotrexate to the nearest 2.5 milligram. Okay. So that is the tablet that is available. So you have a 2.5 milligram tablet of 6MP that is available to us. Okay. Sometimes you have a 10 milligram tablet that can be used, but the supply is quite intermittent in some centers. Some centers say that they get it very routinely and they can use the 10 milligram tablet to adjust the dose so that you can give a continuous dosing. Okay, so try to maintain the same dose every day and make sure that you don't have gaps during the week. Okay, now let's see what happens. So how to adjust the dose? So for the first maintenance cycle one, okay, you are coming out of a recovering marrow. Okay, you are coming out of intensive chemotherapy, the marrow is recovering, so there is increased erythropoiesis, there is increased myelopoiesis. Okay. So at that time, you don't try to bring down the dose. You continue 100% dose, and if the level is slightly higher, you don't bother about it. Okay, but your aim is to keep the neutrophil count between 750 to 1500 and platelet count more than 75,000. Do not adjust the doses for low hemoglobin or raised liver transaminases. You have to find out the cause of the low hemoglobin, but you don't need to adjust the doses. So antimetabolites need not be withheld for transaminitis, but if there is cholestasis, a rise in conjugated bilirubin, obviously, 6MP can cause SOS, okay, sinusoidal obstructive syndrome. Okay, so you have to make sure that you don't cause, if there is cholestasis, you have to interrupt the dose at that time. Okay, for transaminases, you don't need to do that. And if you are checking the bilirubin, check whether it is raised conjugated hyperbilirubinemia or it is unconjugated. If it is unconjugated, you can look at other things that is causing it. We have patients where we have identified Gilbert syndrome as one of the causes for transaminitis. Okay, so keep these in mind, and the only reason why you would interrupt or adjust the dose is because of raised conjugated hyperbilirubinemia or conjugated hyperbilirubinemia. Okay. Now, just coming back, we said that you don't adjust the dose if during the maintenance one. So maintenance one up to 8 to 12 weeks, they say you need not adjust the dose. After 12 weeks, sort of the marrow has calmed down, and at that time you can start increasing the dose. Okay, if there is increased white cell count. Now, major problem comes when you have increased neutropenia, and that is not a cause during maintenance one. So if you have neutropenia, that is a neutrophil count less than 500 and platelet count less than 50,000, you can stop the 6-MP and MTX, monitor counts weekly. Okay. Once counts recover more than 1,000 and platelet count, the ANC more than 1,000 and platelet count more than 75,000, you can resume at 100% of the recommended dose. Okay. This is for the first interruption. For the second interruption, the rules will change. For the first interruption, it might be multiple reasons. We see a lot of post-viral myelosuppression, and during the post-viral myelosuppression, these counts will drop down and they will recover. So you don't adjust the dose during the first interruption. If there is a second interruption that follows, then obviously you are giving a higher dose and you are having multiple interruptions. At that time, you can reduce the dose. Now, how much to reduce the dose is something that is debatable, and there is no guidance on that. The COG says that you reduce the dose by 50% and increase every 4 weeks to from 50% to 75%, and then you can go to 100% if that is well tolerated. So every 4 weeks you can increase the dose. Okay, and that is what we would follow in most of the places. But again, some people say that you did not reduce by 50%, you can reduce only by 25%. Now again, that will depend on your experience. You just have to titrate it a little bit. If it is about between 750 and 500, I would just reduce 25%. If it is prolonged neutropenia, if I had to interrupt for more than a week, then probably I would reduce by only 25%. If it is prolonged neutropenia, then I would decrease by 50%. Okay, so those rules are not clear cut, but there's just a guidance that you need to follow and you need to titrate according to your experience. Okay, now about higher doses. So if the neutrophil count is persistently higher than 2,000 for 4 weeks, then first you assess compliance. How do you assess compliance? Of course, you ask the patient, but then the history might not be always reliable. Then you can look at your MCV. If there is RBC macrocytosis, and you make sure that your patient does not have thalassemia, and if you see that the lymphocyte count is also low, then you know that, okay, this patient is telling the truth, he is compliant. Okay, now if compliance is established, and if the platelet count is more than 75,000, then increase the dose of 6-MP by 25%. Okay, so increases by 25%, and that increase can happen every 4 weeks. Okay, but you have to remember that you don't increase only 6-MP. Methotrexate is equally important, as I showed you earlier. So methotrexate is equally important. So if at week 1 you have increased the dose of 6-MP, the next time you increase the dose of methotrexate. Don't go on increasing the dose of 6-MP and your methotrexate levels remains at 2 tablets. That is not going to be helpful. Okay. Now that is what it is saying further. If the neutrophil count is still above 2,000, then increase your methotrexate dose by 25%. Subsequently, dose escalations can be made every 8 weeks using the same approach. So alternately, you can increase the dose of 6-MP and MTX. And there are some patients who will just not budge. They will require increases every 4 weeks. You're seeing you are increasing either methotrexate or 6-MP. But there are patients like this, and mostly this occurs in adolescents, where if you calculate the dose, you are giving underdosing them. That is what you will realize, because you are not used to giving 3 or 4 tablets of 6-MP every day. Okay, and what is the maximum dose of 6-MP that you can give? There is no ceiling. Okay, they say you can give twice the dose. So 60 mg per meter square is what we have said. What we have prescribed in the ICL protocol. You can go to 120 mg per meter square without hesitation. Okay, similarly for methotrexate, from 20 to 40 milligram per meter square, you can go without hesitation. If you're increasing the dose, make sure you're monitoring the liver enzymes at that time, and you will interrupt only for conjugated hyperbilirubinemia. So that is how I would adjust the dose of 6-MP and MTX. So now you are seeing that your counts are persistently low. Okay, now we come to the other spectrum. How you will troubleshoot. You have tried your increase in doses, okay, or interrupting therapy. Sorry, if you have tried interrupting the therapy or giving lower doses, but still it continues to be low. At this time, I'm sure you have checked your TPMT and NUDT15 mutations. If you have a TPMT or NUDT15 mutation, or if you are persistently low, the first thing I would do is drop the dose to 10% of the prescribed dose. So go to 10% and see if you don't have any DD15 levels. You go to 10% of the dose and see if that is well tolerated. And if that is well tolerated, then you know your answer, it is NUDT15. That is the most likely cause in our population. Okay. But other things that you want to look at is you can withhold the cotrimoxazole because that can also lead to myelosuppression. Consider parvovirus infections. Of course, you get pure red cell aplasia, hypoplasia with parvovirus, but again, it can cause all the cell lines to drop. And then ultimately relapse is something that you have to think of. And of course, a peripheral smear will help you guide whether you need to look at doing a bone marrow for this case. So if there is persistent thrombocytopenia, there are some patients who have persistent thrombocytopenia, check your liver enzymes. There can be VOD or SOS. And in that case, you want to interrupt your therapy. And there are some patients where the platelet count is persistently low. It is hovering between 70s to 125 or 75,000 to 100,000. Okay. And they remain like that even after completion of treatment. In that case, I've checked the liver enzymes, I've made sure everything is okay. I will not bother about the platelet count unless the patient has bleeding. So some patients have that low platelet count and you are okay with giving that 6-MP and MTX without hesitation, right? So this is what we have discussed about the practical points of giving the 6-MP and MTX. Okay. Now let us look at the challenges. Now it is okay to break the 6-MP tablet into half, but there was a study that compared breaking the tablet in a very controlled setting also gave a variable dose. So the segments that were cut of a 50 milligram tablet range from 16 milligram to 47 milligram. Okay, which means you are either giving 50% of the dose or you're giving 150% of the dose. So this is what happened when they broke the 50 milligram tablet into quarters. Okay, quarters means 4 parts. Okay, and the dose went from 15 milligram to 45 milligram. Of course, you are getting most of the patients between 25 to 35 milligram. But again, you are giving a variable dose. Okay, so it is not very easy to break the tablet. We consider it very easy, but it is not. Okay, you are giving a variable dose every day if you are breaking the tablet. So that is something you have to remember. Okay, so what they did was they tried to see whether 6-MP can be given as a tablet, capsule, or a suspension. And they found out that if you have a suspension, that gives the most appropriate dose and a stable dose throughout your treatment. Okay. Encapsulated tablets had poor bioavailability. Okay. And you have to remember that 6-MP oral bioavailability is only 20%. So because of first pass metabolism and it is also deactivated in the gut. Okay. So the best results were obtained for a suspension as compared to the tablets or capsule formations. Okay. So now many of you know that we have Preval that is available to us for the last 1.5 to 2 years. And this is something that has been developed indigenously. So it was done in a very systematic way. What they found out was that it is a novel way of compounding the drug. So it is called 6-MP for oral 6-MP powder for oral suspension. So this is when they did the studies in adults, they found out that the bioavailability was higher. So if you are giving a 50 milligram, 60 milligram per meter square dosing, okay, you have to go down 20% to 48 milligram per meter square. So it has increased bioavailability, 47% higher bioavailability. So when you're changing from a tablet to a suspension, you have to decrease the dose by 20%. Okay, for an established dose. So, and we have done these studies, and we have found out that that is the correct dose. Most of the patients tolerated this very well. The 80% dose, starting dose of 6 MP, or whenever we converted from tablet to 6 MP suspension, that was the appropriate dose to start. Some patients, as usual, will require titration, and we found out that around 30 to 40% of the patients required titration, as anybody else would require. But the ones who had a stable myelosuppression, out 7 patients had stable myelosuppression on the tablet, and when we started at 80% of the dose, 6 out of those 7 did not need any dose titration further. So 80% is the correct dose that you are giving. So if your prescribed dose is 60 milligram per meter square, you can give 48 milligram per meter square, round it up to 50 milligram per meter square, and give the 6 MP suspension. Now you have to remember that the 6 MP suspension, it is powder for oral suspension. So the powder settles down. So you have to tell them that you have to shake the bottle every time you are giving it to the patient. So that is one advice that you would give when you give the pre-vial suspension. Okay. Now, one more thing people ask is, there have been studies where they show that there is a circadian rhythm, and you can give it anytime. The food restrictions that are with come with 6 MP. So there are studies that have been done by COG where they felt that no such thing exists, and there were outcomes were comparable. But I feel that in the Indian patient, if you give them a ritual, they will follow it very well. So if you tell them that 2 hours after meals, before going to sleep, you give them 6 MP, they will follow that religiously, because that is what they will remember. If you tell them any time of the day is fine, then obviously there are going to be variations, and the compliance or adherence will go down. So whatever, you tell the same thing for all the patients, because again, patients are talking to each other. So if you give them a ritual, they will follow. So we are following that, which I feel may be more practical than evidence-based. But the practical point is that you give them a ritual and they will follow it. So 2 hours after meals and not with milk, so that they will remember. Okay, great. So thank you so much. And I'm sure that there will be some questions, but I'm here to clarify. Thank you.
Thank you, Dr. Chetan Damne. Wonderful lecture. Fantastic. I think you're a wonderful teacher. Thanks a lot.
Thank you. Thank you.
I request now all our discussants to please put the hand raised sign. So we'll start the question session with Dr. Chetan Damne. So, in the meanwhile, when the questions start pouring, I have some questions for you.
Yeah.
Regarding ALL maintenance, there is always to those patients. Is it required prednisone or only 6 MP methotrexate are fine?
So there are studies where they have we give the VCR dexapulse or VCR prednisolone pulse, which was given in some of the protocols. But when they compared the outcomes, they did not find any major difference in the outcomes, especially the overall survival. Now, what has been thought of is that maybe when you are trying to reduce the intensity of treatment in your intensive phase, at that time you would be better off giving the 6 MP, giving the VCR dexapulses if you are reducing the intensity of treatment upfront. So that is something that has been thought of and proposed. Also, for patients who have IKZF1 deletion, there is some evidence to show that the VCR dexapulses might be useful. So these are the two situations. But again, there is no clear winner, and there is no clear guideline to say that this is definitely what you should do. The outcomes between giving VCR dexapulses versus not giving, overall survival remains the same.
Thank you. One question has come from Dr. Krishnanathan Kannan. How will you manage acute pancreatitis due to 6-MP? Can you re-challenge the drug?
Yeah, so there are reports where they have said that 6-MP can develop pancreatitis, which is known. And we have had one or two such patients, just one that I remember offhand, but it was during induction that this patient developed pancreatitis, and we did not know whether it was because of the 6-MP or the aspergillus. We gave this patient maintenance with 6-MP and he tolerated it well. Now, if it is clearly attributed to 6-MP, then probably you might not be able to give the 6-MP. But again, that is something that I would like to ask a cumulative experience rather than just one case report or few case reports. But ideally, you would not re-challenge once you have developed pancreatitis.
Thank you. Dr. Gopinathan, your question.
Good morning, sir. Thanks for that excellent overview.
Thank you.
My question is regarding maintenance in TALLs. And how do we differ? And is there a role of nelarabine? Suppose for some patient we have not used nelarabine upfront. So I can see some papers quoting nelarabine towards the later end of reinduction also. So is there a role for that?
So again, this data is evolving. Nelarabine has shown to decrease the incidence of CNS relapses in TALL. But again, that is controversial because in one of the trials, they had given radiation to all their patients. In the other trial, they felt that the aspergillus dose was higher. So there is no clear-cut evidence to say that nelarabine is definitely going to decrease the incidence of relapse. But for TLL, there is a general feeling that nelarabine might be helpful. Okay, because the trial also compared Capizi versus high-dose methotrexate, and Capizi methotrexate was found to be more useful than nelarabine itself. Again, the problem with nelarabine is that it can cause neuropathy, which can be quite distressing for the patient. So the clear-cut benefit is not really shown. And also in the trial, they felt that those who are poor responders, they did not do well. I mean, there was no statistically significant difference for those who did not respond to therapy better. Or those who are post-induction, post-consultation MRD positive, adding nelarabine did not show a clear-cut advantage. So where to add nelarabine is something that is difficult to say. Now that we have nelarabine, it can be used. But again, I would collect that data prospectively rather than just giving it to one-off patient. But that is something that can be thought of. Not a very clear answer that I can give because there is no clear-cut evidence. These papers that you are quoting are emerging evidence, but no clear-cut answer for that.
Your protocol for checking viral reactivations during maintenance.
No, so most of our patients are from outside of Mumbai, and they do develop fevers. That is the time we stop the 6-MP. We do not go into identifying the virus. We don't need to do that. Most of these patients will recover. These are common viral infections that occur. And you know that these patients are lymphopenic, so they are prone to getting viral infections. So we will not check any viral infection particularly. Reactivations can occur. You can see varicella reactivation. So you can get herpes zoster in these patients. There's a lot of molluscum that I see in some of the patients. Some of them will have warts that will come. But once you stop therapy and the lymphopenia starts recovering, all these will disappear.
Thank
you. Thank you, Dr. Gopinathan. There are some more questions from the audience. Dr. Krishnanathan Kannan wants to know, can you go for 6 days of 6-MP and 7 days of methotrexate?
So that is one question that people have. Yes, so Archie Blair especially is looking at that. But again, methotrexate, if you go continuously, again, you have to worry about mucositis, you have to give a rescue. So those are some of the things that we are not sure. Right now, we want to reduce the pill burden. We want to make sure that we have consistently given the 6-MP, which is the most important component, and then give the methotrexate once a week. So giving IV methotrexate in the Mary Relling paper that I showed, it did not really improve the outcomes as much as it was thought to. So giving higher dose of methotrexate or giving a continuous dose of methotrexate will have its own problems. So currently, the maintenance is set in stone, giving 6 MP and MTX as the two drugs that we are giving, and not to play with the dose of methotrexate. But that is something that people are thinking about, and maybe there are small pilot studies that might come out.
I think his question is about giving 6 days of 6 MP from Monday to Saturday, and 7th day only methotrexate.
Oh, 7 day. Okay. So, sorry, then I got that wrong. Basically, the 6 MP and MTX work best when they're given together. So we do tell them to take the 6 MP in the afternoon and MTX in the afternoon and 6 MP later. But going by the theory, we would like to give them together, and giving both of them together the day you are giving the MTX would be better. If you are missing 1 day of 6 MP, okay, then you are sort of you are rescuing some of the cells that are coming into the synthesis phase during that time. So a continuous dose of 6 MP is what I would advise, and not give a 1 day gap. And the methotrexate, I would prefer, based on the theoretical discussion, theory or literature, prefer to give the 6 MP and the methotrexate together the day you are giving the 6 MP.
Thank you. Another question from Dr. Anil Kumar Yadav. Does the maintenance dose escalation depend upon the high genetic markers also?
So genetic markers for escalation, again, we are not looking at a lot of these genetic markers, so it is very difficult to comment. But I'm sure that this is a very complex pathway and interaction between the de novo synthesis of purines as well as the 6 MP metabolism that occurs within the cell. So because there are multiple enzymes that are involved, there should be inter-individual variability. So I would titrate more for the neutropenia. That is what we have best at the moment, and not worry about the genetics. But definitely genetics will play a role in titrating the doses. Higher doses, not much of genetics is available to suggest that these are the mutations where you have to increase the dose of 6 MP or MTX.
Thank you. Another question from Dr. Rachit. What is the preferred assay for checking TPMT and NUT15 mutational status?
So we do pharmacogenomics, and in Mumbai at least we send it to Nair Hospital, where the Department of Pharmacology is doing those tests at a very nominal rate. So anybody can use those. We can do it in-house also, but it is something that we are looking at.
Thank you. Another question is from Dr. Forum. In pH positive ALL, what is your approach to maintenance and the TK duration and the dose?
Right. So that is again something that is important. So when you're giving maintenance for pH positive ALL, you have to remember that you're treating the leukemia first. So you need to give 6 MP MTX continuously, along with dasatinib that you're giving. Some patients, some people might be giving imatinib, but we are thinking we are following dasatinib. So giving dasatinib at a particular dose that has been established during your initial phases is what you would give. You will not increase or decrease the dose during maintenance. If there is an interruption, there are some people who say that you can interrupt the 6 MP MTX and continue the dasatinib. So that is one way of looking at it. But again, what is recommended is that you want to start the 6 MP MTX sooner than later, because your entire theory, entire backbone of maintenance is 6 MP MTX. So you want to start 6 MP MTX as soon as possible. Dasatinib, if you hold for a few days, even in CML, if you interrupt therapy, it is not going to lead to a lot of different outcomes. So starting the 6 MP MTX would be your priority. But if you want to continue dasatinib and it is not causing a lot of myelosuppression, that is something that you can try.
Thank you. Another question is from Dr. Anil Kumar Yadav. Is the dose common for all ages of pediatrics, or any changes with the age in respect to 6 MP and methotrexate?
Yeah, so the dose is 60 milligram per meter square of 6 MP and 20 milligram per meter square for methotrexate per week. We adjust the dose for the myelosuppression, for the neutropenia. You want to keep the ANC between 750 or 500, depending on what is more acceptable to your patients. If I'm able to follow the patient very closely, then I would keep a lower threshold of 500. And I would still continue to give the 6 MP when the dose, when the ANC is between 750 and 500. But if the patient is remote in some village, okay, then I would try to keep that cutoff slightly higher. I would keep cutoffs of 750 or 1000 based on the previous experience, whether he has had multiple interruptions before or viral infections. So you don't adjust the dose for age, but you adjust it for the ANC. The highest ANC I would keep is 2000. Recommended is 1500, but 2000 is what is tolerable. More than 2000, I would definitely increase the dose. So dose is adjusted for ANC and not for the age.
Thank you. Another question, Dr. Pakiresh Reddy. Some of the patients in maintenance develop splenomegaly with cytopenias, but cytopenias increase gradually, but not the splenomegaly. And there is no release after workup also. There is no reason after workup also. So what is the reason for splenomegaly? If the patient develops splenomegaly on maintenance?
Not seen particularly any patient developing splenomegaly during maintenance. Some patients have ITP, but again, we have not seen a lot of splenomegaly with patients on maintenance. If anybody in the group has some experience with looking at splenomegaly, they can please comment.
Not same. I've got some more questions for you.
Sure.
Regarding the ANC which you need to keep, what is the actual ideal ANC which you need to keep in maintenance when you are giving 6 MP methotrexate?
So
Is it
ideal ANC should be between
total count?
750 and 1500.
How much?
Total count will vary. So ANC 750 to 1500 is the ideal that you would like to keep. Okay. Now you see, we have a lot of these viral infections. Patients will have one odd count will be more than 1500. Okay. But I would not change for every increase in ANC. I need to see at least two counts that are higher or lower. Okay. If it is lower, obviously you will interrupt. But if it is higher, I would wait for at least two counts, because there can be lab error, there can be some sort of underlying subclinical infection because of which the white count has gone up and subsequently your ANC. So two counts higher is the that is the indication for me to increase the dose. A single rise in ANC will not increase my dose.
Correct. Another question from Dr. Krishnanathan Kannan. Do you advocate shingles vaccine or varicose zoster vaccine during maintenance?
No, so see, varicella vaccine is a live attenuated virus. Okay, so I would not give any vaccines during maintenance unless there is a breakout. If there's an outbreak, but the vaccines that we give 6 months after completion of maintenance is what I would follow. If there is reactivation of the virus, obviously you see that you give acyclovir and it comes under control. So your immunity is still active. It is not that your immunity is not working at all. It is not 100%. If you get a reactivation of varicella, it is controlled, and that has to be something that you have to be monitoring the patient. So in case there is any fever, you just make sure that the patient is examined. And if they have vesicles, you start your acyclovir as soon as possible. So that is what I would say. But vaccination is not something that I would give during maintenance. Your lymphopenia is the maximum, like the lowest lymphocyte count during maintenance. So giving vaccine, which is a live attenuated vaccine, is not advisable during maintenance unless there is an outbreak. And post-exposure prophylaxis with acyclovir works excellent. So you have to, I would not recommend vaccines.
Thank you. How different is the maintenance therapy between adults and pediatrics? Any difference?
Not really, because the altogether protocol or the Western protocols use the same protocol up to 45 years of age. So there is no difference in maintenance in adults and pediatrics.
Thank you. Dr. Saurabh Pandey has a question regarding the pulse steroid and the VCR, which we are using in maintenance. Again, the same question. Is there really a role of pulse VCR and pulse steroid in the maintenance, number one? if we are using pulse steroid, then Dexa is preferred or prednisolone is preferred?
So again, as I said earlier, that the OS remained the same. Initially, the pulses were given every month, and then they did a trial where they compared 3 monthly versus one every month, and they did not find a difference. What they have seen is that when there is an IKZF plus disease, that is the time there might be some usefulness of doing BCR DEXA. The DEXA controls the CNS disease better, so DEXA might be preferred. But again, DEXA causes a lot of myelosuppression, or it causes lymphopenia. So that again causes problems. So overall survival remains the same, and only if you
And for pediatric ALL
yeah, it's the
maintenance
same
and
as I
TALL,
mentioned
B
earlier.
cell ALL and TALL, what is the difference in the maintenance?
No
And
difference
about
in
H
maintenance.
positive ALL?
Would keep the same. Adding dasatinib, which you have already added at the starting of treatment. The duration, as I said, I did not mention the duration in the previous answer. We give 2 years of maintenance and stop all the medications, including the dasatinib.
2 years dasatinib stop.
Yes. So when you stop the maintenance, you stop the dasatinib. There are select cases where we felt that there is some sort of this is again anecdotal. I would not recommend it. None of the protocol will recommend continuing dasatinib beyond the 2 years. But in 1 or 2 cases where we felt that the patient was slow to respond or the BCR-ABL was still positive, we have continued the dasatinib. But again, this is very much arbitrary, and it is not protocol driven or in a guideline. The recommendation is to stop at the end of maintenance.
And for both BAL and TL, about 2 years maintenance.
Maintenance is the same in the current protocols.
Thank you. Dr. Anil Kumar Yadav has a question. Any reason behind 3:1 ratio of 6-MP in methotrexate? Can we change in any special situations?
So again, when we titrate the dose, we are not maintaining that exact ratio of 3:1, 60 versus 20. Basically, this has come from experience that has built up over the years, the dosing that we have come up with, 60 mg. And again, it will differ from protocol to protocol, because in the Western world, you give 75 milligram per meter square and 20 milligram per meter square of methotrexate. So the dose is based on the neutropenia that you achieve and the overall outcomes.
Thank you. Dr. Akshay Mandloy, your question.
Thank you, sir, for the wonderful talk. So I have one question. In a patient who is clinically stable on maintenance, but peripheral blood is showing thrombocytosis and presence of 3 to 4% blast on 2-3 occasions, how should this be approached?
So I think in such a patient where you have 2 cell lines that are affected, you are seeing blasts. That means your WBC count must be higher, or there are some atypical cells that are present, and there is thrombocytosis. So thrombocytosis would suggest that there is a healthy marrow. So I would not worry so much. Sometimes if there is a viral infection, you can get atypical cells. These are viral. These are the T cells that are lymphocytes that are acting against the virus. So there are atypical cells. I would not consider them leukemic blasts. Okay, but for such a patient, I would monitor carefully. Thrombocytosis as such, if your patient is compliant and the dose of 6-MP MTX is adequate, is not something that I would intervene at any point. But I've not come across a case like this where you have thrombocytosis during neutropenia. You have to look at other reasons for thrombocytosis in such a patient.
Any other question?
Thank you, sir.
Thrombocytopenia, definitely I would consider doing a marrow, but thrombocytosis, no.
Thank you. Another question is regarding the 6-MP TPMT and NUT-T50 mutation status. Do you routinely do it before starting 6-MP therapies?
No, we don't routinely do it, but we always check back before starting the maintenance. We always check back and see whether the patient has had prolonged neutropenia during other cycles of chemotherapy, especially the consolidation phase or the delayed intensification phase.
Thank you. In the patients who have developed a very severe neutropenia with the lowest possible dose of 6-MP, say for example 12.5 mg also, recurrent neutropenia, very severe neutropenia, profound neutropenia, how do you deal with such patients? Do you stop the therapy almost completely, because then there's a risk of relapse afterwards?
Correct. So we most likely this patient is a NUDT15 homozygous in our population. So in such a patient, we have had patients like this where we have given the 6-MP suspension, and we have given 10 milligram daily dose. So 0.1 ml of 6-MP suspension has been given on a daily basis, and that has kept the neutropenia under control for our patients. So that is something that we have seen, and we have delivered a very low dose, and a low consistent dose is what would keep these patients into remission rather than increasing or decreasing the dose. So don't titrate the dose. If you feel that there is severe neutropenia, as soon as you start your 6-MP MTX, then you go at 10% of the dose and go as low as 10 milligram per day and try to titrate from there, titrate above from there.
Thank you. From the same note, can we go for alternate day schedules of 6-MP?
Can be done, because these are patients who have decreased metabolism, and the 6-MP might stay for longer duration of time. But again, when you're cutting, as I showed earlier, when you're cutting the 6-MP tablet into quarters, you're giving an inconsistent dose. So I would prefer giving them suspension that is readily available and affordable to our patients. I would go with suspension and a daily dose rather than an alternate day dose for this patient.
Thank you. There is one more question related to persistent transaminitis during maintenance. At what bilirubin level and at what SGOT, SGPT level would you like to stop 6-MP almost completely?
So again, I would stop only if there is conjugated hyperbilirubinemia. If there is transaminitis, I have not stopped. In such cases, what you would do if you are worried about it, about the transaminitis, you can try combining the 6-MP with allopurinol. That will bring down the methylated 6-MP metabolites, and that will give you lower levels of that transaminitis will come down. But remember, when you're adding allopurinol, you have to bring down the dose of 6-MP by 50%.
Thank you. There was one debate which was always going on previously also regarding the maintenance different for boys and girls before it, which just came, 2 years versus 3 years. Is it really justified? How strictly do you follow this?
Right. So in the previous protocols, definitely they felt that the boys have an extra century site and they did worse. Also, something related to the metabolism. That is why the boys get 3 years of maintenance as versus girls who get only 2 years of maintenance. And that was very well established in the previous protocols. Now, with increased intensity of our upfront protocols, with the use of high-dose methotrexate, there is no need to give a longer duration of maintenance for the boys. The outcomes are not inferior. So everybody gets only 2 years of maintenance, not beyond that.
And that is true for standard risk as well as high risk both.
Yes, all the risks. Yes.
Any debate or any counseling to be done to the patients on how to take 6-MP? Whether you take empty stomach or at a night time, morning dose, evening dose, anything difference in that?
Yeah, so there have been studies previously, it was mentioned that you have to take it empty stomach, not with grape juice and not with milk. And because of circadian rhythm, they felt that it was recommended that you take at night. Okay, but that when COG did a study and compared patients, they found that there was no difference in outcomes of those who took it with food and without food. And it is basically related to the xanthine oxidase in the stomach when you take milk. But that decreases the viability of 6-MP. But having said that, for the Indian patient, if you give a ritual, they will follow that strictly rather than giving them some midday when the child is going to play, is going to school. So nighttime is the best time. That's what I feel from the Indian perspective. And that is where the parents and children are all together and they will follow that very strictly.
Thank you. Another question related to MRD positivity after consultation and then you're starting maintenance. Patient is not eligible for transplant or not affording for transplant. And you put the patient directly on maintenance with MRD being positive after consultation. In that scenario, whether the 2 years can be made 3 years, 4 years maintenance?
This is a very hypothetical question because if MRD is positive, I would rather try to get him into remission before starting the maintenance. because maintenance is only going to keep you under control at less than MRD level disease. Okay, for that occasional blast that has been left behind. So not much experience or I'm not heard of anybody starting maintenance if the MRD is positive. I would rather give him newer therapies like Blena, which is now available at many centers, and try to bring him into remission and go for transplant. Post-consultation MRD positive is an indication for transplant. I would transplant this patient by getting him into remission by using other doses of chemotherapy, because post induction and consolidation, you still have high dose cytarabine, high dose methotrexate that are able to bring this patient into remission. Fludarabine, there are some
The patient comes into remission, for example, never opt for transplant. Then can you
for transplant.
then you escalate this maintenance for the period of 2-3 years?
If the patient stays in remission, you might extend it. That is okay. In such cases, I would consider giving BCR DEXA pulses for such a patient. But again, it is just by chance. There is no clear-cut evidence to show that it might help or not help.
True. I think let me see some more questions. Fine. I think that's all. So one last question is about the nature of relapse during the maintenance. Is it aggressive relapse or the same relapse, or there's no difference? Because if relapse occurs during maintenance, are they really resistant to the next line of treatment as compared to relapses occurring in front line?
No, I did not get the question. Relapses on maintenance, right?
During maintenance, yeah.
During maintenance versus end of maintenance. Right?
Versus end of maintenance, yes.
End of maintenance. So relapses during maintenance are because of a few reasons. The biology has boiled down to there being a resistant clone that is present. So that is chemo refractory. Okay, so you have to use novel agents, or you have to try to get them in remission and make sure that they achieve complete remission before you go for transplant. The patients who relapse later or late relapses, there might be a predisposing clone that has developed an additional mutation and now has developed a relapse. Okay, so the predisposing clone is present while the leukemic clone has gone. So the early relapses will have a persistent chemo-refractory clone that comes up, while a late relapse will have a new mutation in a predisposing leukemic cell. So that is what is known by theory. But there are certain the early relapses we have looked at our early relapses, and we felt that MEF2D is one of the mutations where you have an early relapse. PAX5 is something that we have seen an early relapse. If you have some of those mutations that are conferring 6MP resistance, like I showed, NT5TC mutations. Okay, so those are the ones that can have an early relapse. But again, these are chemo refractory clones, and they will have an aggressive relapse.
Thank you. So I finished all the questions from the chat box, and there are no more raising signs. Thank you, Dr. Damne. Yeah, Dr. Rama.
So, yes.
Yes, please go ahead. Do you have any question, Dr. Rama? Well, so
Yes. Am I audible?
yes, you are audible. Please go ahead.
So, if I have not heard wrong, did you said regarding MLH in the ALL, or is it MLL?
We didn't get your question.
MLH hypermethylation or MLL gene mutations?
For early relapse?
Yes, in relapse cases.
MEF2D and PAX5 are the ones that we feel are having an early relapse. Okay, the MLL gene mutations, generally you want to treat them on a higher risk protocol, and if they are post-consolidation MRD positive, you go for transplant.
Okay. And for these other mutations which you mentioned, like PAX5 mutation and all, so if you are detected it in the IHC, like PAX5 is strongly positive, so do you have any treatment option?
It's not on IHC, it is based on the NGS. Okay, and if there is a PAX5 mutation, we have seen we are treating on high risk, but we have not been able to really say this is our protocol. So we don't know whether we need to augment the protocol further for them. But they are generally now treating on high risk. And if they are chemorefractory, they will go for transplant in CR1.
Okay, so final option is a bone marrow transplant when we are detecting these kind of mutations.
No. Only if they are MRD positive. It is all MRD directed therapy. We still don't know whether that is going to be helpful or not. Okay, because in transplant, you have to remember it is not only in ALL, you have minimal anti-leukemia effect. Graft versus leukemia effect is minimal. So you still have to get them into complete remission and hope that the TBI works better. Okay, so recommending transplant upfront for this patient again, if they achieve a MRD negative disease, is not something that is advisable at this point. We need to look at our cohort and try to design newer ways. And because these patients are very few, we might not be able to come up with a particular specific answer for such patients. But we know that these patients will have an early relapse and higher incidence of relapse.
Okay, even the NGS is suggesting these mutations, it should be like detected in the MRD, not
They should be
MRD
MRD positive. Yes, they should be MRD positive if you want to transplant them in CR1. Okay, but definitely there is an increased risk of relapse in such patients, and you treat them on a high risk protocol.
Okay, thank you, sir.
Dr. Gaurav is here if he has any questions, comments regarding some of the questions that were asked.
No, I think you've covered it very, very exhaustively, actually, Chetan. So, in fact, I've learned a few things. Thank you so much.
Thank you. Thank you.
So thank you, all of you, and wish you a good day today. And thank you, Dr. Chetan Damne, for wonderful, wonderful lecture, wonderful talk. I think all the doubts were very superb and very clear by your talk. And what a wonderful question session we had with you. It was almost 45 minutes of question session, and you solved all our doubts very nicely. Thank you so much.
Thank you. Thank you. Have a good day.
Thank you. And we'll
Thank
meet next Saturday. Thank you so much.
Thank you.